So thank you very much. Thank you very much, Deb, for inviting me to come and speak to you all today. And congratulations on putting this whole thing together. I think you've done a fantastic job. It's great to see so many people here before me today and interested to hear what I've got to talk about. And thank you. I enjoyed our initial conversation just as much. Thank you. So first slide is just to remind me who I am and where I come from and what I'm here to talk to you about. And I've realised amongst all the talks today, I've been asked to talk to you about history. And who likes history at school? I don't know. Certainly not me. And then also the experience of NMO in Australia and New Zealand, which I'm going to sort of talk to you a little bit about some of the negative stuff. So I hope this doesn't affect anyone too much. But I'm going to give you the picture as we see it at the moment in Australia and New Zealand. And then Mark and Sally are going to tell you about all the positive stuff in terms of treatment and things you can do from a psychological point of view to improve your life, which is great. And then Michael, my colleague in the US, gets to talk to you about the future, which is even better. And the stupid thing is I put the program together. Anyway, so a little bit of history. So a guy called Thomas Albert in about 1850, so over 150 years, in fact over 160 years ago, was the first person to write up a case of someone who developed both optic neuritis and what we now call transverse myelitis or spinal cord disease. Didn't really realise what it was at the time. And it was a French colleague, Eugene Devic, in Paris, who wrote up about 6 patients that he first put together who had pretty much simultaneous optic neuritis and spinal cord disease. And he described the pathology, which he recognised even then. In fact, the first descriptions of the pathology of MS were only just coming out at that time, but he recognised that it was different to MS. So this condition has been known about for 160 years or more. Down the bottom here is there's a thing that scientists use called Medline or PubMed, where we search for papers and articles. So if you put in neuromyelitis optica or Devic's disease, this is the printout you get of publications per year since 1937, which is when the repository starts. And basically, you'll notice that there was nothing, pretty much. There were occasional case reports, and we really didn't know what this condition was. And there was lots of discussion. Is it MS? Is it just something completely different? Is it just only when it happens together that you get optic neuritis and the spinal cord disease? Lots of discussion, but it was all speculation. Again, the consistent thing was people noticed that the pathology was different. So unfortunately, when people came to post-mortem and people looked at their spinal cords and their brains under a microscope, they noticed things looked different to MS. But that was essentially all we knew. And distinguishing that clinically before people died, and thankfully most people don't die, either with NMO or MS, then you just couldn't tell clinically. Picking them apart, there were a few cases which were very typical, which people kind of recognised were a bit different and didn't seem to respond to the same kind of treatments, but we really struggled with it. And then this lady, Van der Lennen, who is an Australian, but she works at the Mayo Clinic in the US, described these antibodies. So these bright green patches on these micrographs here are basically immunofluorescent staining of antibodies latching onto bits of brain tissue in mouse brain mostly, also mouse kidneys. And so she described this antibody directed against the aquaporin 4 channel, which is a water channel. So this is a protein that sits in the cell membranes and simply allows water to flow in and out, and there are various mechanisms that help control whether water goes in or out. And this antibody blocks those channels. And she realized that this antibody was only being found in patients who had this specific combination, particularly of optic neuritis and very long spinal cord lesions. So initially, they thought it was just picking up what we had always called Devic's disease, which is when it occurs together, or roughly at the same time. But they then also realized it was picking up a whole load of people who were having these kind of similar events, but also other types of events, often separated by years, so a relapsing condition. And really that's changed our knowledge. And you will notice that in the 14 or so years since then, the number of publications per year has just skyrocketed. So it's over 400 publications a year now. So there are a whole team of people around the world who are investigating this condition now that we know what it is and we're learning more about it. And finally, you've heard already mentioned the Guthrie Jackson Foundation, who have been fantastic drivers of that investigative effort. So, a very little bit about the pathology. So, these are human spinal cord samples. So these are taken from people once they've died, obviously, and then stained for various things. And at the top there is the aquaporin 4 antibody itself. And in MS, you'll notice that you can stain for this, and basically it all lights up as a sort of pink color. And so the aquaporin 4 water channel is there, and the antibody binds to it. In NMO, there are patches where it's very pale, and that's because you've lost the water channels in those patches. You also can stain for astrocytes, which is where these water channels are most predominant, and you'll notice that the bare patches match up almost exactly, which tells us that it's the aquaporin 4 on the astrocytes that are being primarily attacked, and it's the loss of astrocytes which causes the damage. Now, in both conditions, you lose myelin. So the difference is the loss of the astrocytes occurs much more predominantly in NMO. So this is my little schematic. It's a very common thing in medicine. If we don't understand it, you draw a very brightly coloured picture. So the thing on the left that looks like a kidney is not a kidney, it's a lymph node. So that's where our lymphoid cells live and produces lymphocytes, which come in two types: T cells, which can attack cells and bacteria and viruses and things directly themselves, but then also B cells, which produce antibodies that we then also fight infections with. And they come out into the blood, circulate around the body, and normally they fight infections. But for whatever reason, in people who develop NMO, they produce antibodies that are specific against aquaporin 4, and for some reason these antibodies become activated and they induce your immune system to attack astrocytes, which is the big blue thing up here. Astrocytes are basically the scaffolding of the nervous system. So they're cells that provide structure for both oligodendrocytes, which produce myelin, and the neurons, which are obviously the cells that conduct the electricity that make us work, and the astrocytes bind it all together. They also form a crucial part of what's called the blood-brain barrier. So the blood, most of what's in your blood doesn't go into the brain. It sits in your arteries and veins, but some cells are allowed through, and at certain times, particularly when your body's inflamed with anything, the immune system is allowed in, and that's what helps protect our brains, presumably from viral infections and meningitis and all those sorts of things. And because of that, the astrocytes come into contact with the immune system probably more than other cells in the nervous system, or at least they're the first to be introduced to the immune system. As I say, what we don't know is why, A, these antibodies appear in the first place, because usually our immune systems don't produce antibodies against yourself. But because the brain is relatively protected from the immune system, it may be the immune system didn't see that part of us when we were a baby, essentially. And so if that blood-brain barrier breaks down for any reason, the immune system might be allowed. And if you happen to have plasma cells or B cells that produce antibodies against aquaporin 4, that may be allowed to happen. But we still need to learn a lot more about why that process starts in the first place and why it continues. So these are those green blobs again. So this is samples from the lab up in Brisbane. That's probably the main centre that does the antibody testing in Australia. Mouse brain, mouse cerebellum, which is the bit on the back of your brain that controls balance, and then kidney. These are nephrons in the kidney, and they all light up because they have cells that have a lot of aquaporin 4. So the clinical features, we recognised for a long time MS and NMO spectrum disorder were slightly different. And I've heard several stories already this morning that people have taken a little bit of time to get diagnosed, and that's, often just because it is sometimes difficult. Optic neuritis is very common in MS, it's very common in NMO. The differences are quite subtle. Just in NMO it's often a little bit more severe and doesn't recover quite as well. And also it's more likely to be bilateral, but obviously it's not always bilateral. The myelitis, or the spinal cord disease, is very common in both. In MS it tends to be what we call a partial cord lesion, so it tends to affect one bit of the spinal cord, often more to one side than the other, so people present with symptoms down one side more than the other. Whereas NMO, it tends to affect usually the legs predominantly, but it can be the arms as well, but it would affect both sides roughly equally. And in NMO, you tend to have these extensive lesions that go all the way up and down the spinal cord. Both conditions are more common in women, but NMO spectrum disorder is much, much more common in women. So it's about a 3-to-1 ratio for MS, about 9-to-1 for NMO. And then we do these other tests, and I guess the main one is that the brain scans in NMO are more typically, not always, but more typically normal, at least initially. However, there are people with MS whose brain scans can be normal for years before they develop any changes or typical features of MS. So there are lots and lots of different types of lesion which we now recognise are kind of quite specific to NMO. And I won't bore you with them all, but the two things we probably look for the most are these long lesions in the spinal cord. So this grey area is your spinal cord, this is your spinal column, your vertebral bodies. This grey structure at the spinal cord normally is a solid homogeneous grey. This white patch is an area of inflammation where those antibodies are doing the damage. And then similarly on the other side, there's a lesion within the optic nerve, which you can see. So the optic nerve again is the grey area in the middle of the orbit, and there's a white patch in the centre, which is the inflammation. So Dean Wingerchuk, another guy from the Mayo Clinic, very, very nice guy, very handsome guy, is the guy who got his name attached to the diagnostic criteria for NMO. And these are the latest criteria which came out in 2015, which I actually think are very good and for the first time probably truly identify people with NMO. So it's only the last 3 years that we've had very good criteria to diagnose NMO. Sorry. And the crucial thing is the antibody. So we test for the antibody. The test we have in Australia is very good. We've tested it against the laboratory in Oxford, and essentially we got the same results as they got in Oxford. And if you've got the antibody and you have any one of the 6 typical presentations of NMO, you can say someone's got NMO spectrum disorder. And those typical presentations are the optic neuritis we've talked about, the spinal cord disease that we've talked about, and then much rarer, these area postrema lesions. You won't probably have ever heard about the area postrema, but it's a part of your brainstem that's very close to a thing called the vomiting centre. You may wonder why our brains have a vomiting centre, but we do. And it's very close to an area that causes hiccups as well. So getting vomiting, nausea, vertigo, and hiccups often come from these lesions in that part of your brain. You can also get other brainstem syndromes. They're a mixed bag, often of symptoms that come on quite suddenly and can be quite devastating, and we've heard a couple of those stories already this morning. And then there are other sort of rare features that can happen. One is a lesion in a part of the brain that's very much to do with our sleep cycle, so affecting how alert you are, and also your temperature control as well. So there are a few people who rarely present with a very low core body temperature. And then also some other cerebral syndromes that look a bit like what we call encephalitis, which just means your brain's not working. So I'm going to talk to you, how am I doing for time?
5 minutes.
5 minutes, okay. I'm going to talk to you about the ANZ NMO collaboration. So this is an effort that we started probably 6 years ago to define how common this condition is in Australia and New Zealand, to assess the sensitivity of the test, which, as I've said, proved to be very good, and then also define the features as it occurs in Australia and New Zealand. So I'll go through that now. So 35 neurologists across 22 different clinics across the whole of Australia and New Zealand. And we collected lots of information. But the first thing we looked at is simply how common it is. So we actually identified, I think it was 75 people who have NMO spectrum disorder from participation in the survey. We identified a similar number from the laboratory testing. And then that allows us to do a thing called capture-recapture, which is they use to estimate the number of fish in a pond, I think was what they originally used it for. So you catch a number of fish, you tag them with something, you chuck them back in, you come back the next day, catch the fish again, and depending on how many you've recaught, you can actually work out how many fish are in the pond. We used the same technique, and we worked out there's probably about 170 people across Australia and New Zealand. And that gives a prevalence of 0.7 per 100,000. So it's very rare. It's probably an underestimate, because I know of cases in my own area that I couldn't remember the name of, so we couldn't find them. And so it's probably more sort of what's sometimes called a point prevalence, so it's how many patients you can identify within the 3 years that we were collecting data for. And our female to male ratio was 6 to 1. So, and in actual fact, across the world, that's actually turned out to probably be about the kind of average. So this is the world epidemiology, and basically we're very similar to everywhere else in the world, both in terms of the incidence, which is how many cases you get per year, and the prevalence. And it's very interesting in virtually all races and countries that this has been looked at, we're finding similar levels, whereas MS is almost universally a Caucasian disease. It's extremely rare in the Aboriginal population of Australia and in Africa, whereas NMO seems to be common amongst all groups. The other thing is, I'll show you another graph in a minute. So we know that MS has got this marked latitudinal gradient. So the further away you go from the equator, MS gets more common. We've collected, obviously, across a reasonable range of latitudes across Australia and New Zealand, and we've actually found no such trend. If anything, it's going the other way, but it's not significant. So whereas we think the amount of sunlight and particularly vitamin D levels are very important in MS, it may not be the case in NMO in terms of predisposing to the disease. So this is the curve for MS, both in the northern hemisphere, which is the red dots, and the southern hemisphere, which is the green dots, where there's very clear relationship. Again, a little bit different to MS. NMO can occur at almost any age. So this is the age at which people first get any symptoms. So it seems to be extremely rare before the age of 10. But thereafter, you can be almost any age. There's obviously the sort of peak age is between 30 and 40, but even out to sort of 50s, 60s, there's still a reasonable number of people are getting their first symptoms, which is, again, slightly different to MS, which is probably shifted a little bit to the left in terms of being a bit younger in onset. And then we've looked at the various clinical features. And we've looked at differences between different ancestries, because we're in quite a unique position to be able to compare particularly European ancestry with Asian ancestry, and to a lesser extent the indigenous populations of both Australia and New Zealand. And as I said before, in terms of MS, it's virtually unheard of in the indigenous population of Australia in particular, whereas NMO certainly does occur. But there are no real differences. Secondary progressive NMO is extremely rare, and most cases do relapse. But there is a small group who, even after a very long period of time, appear to remain monophasic, so they only ever have one bout of symptoms. The other thing is that's quite distinct from MS is the number of gadolinium-enhancing lesions. Lots of people in the room will have had MRI scans where they give you gadolinium. Lesions that enhance with gadolinium are not very common in MS, but we definitely see them reasonably frequently, whereas you actually very rarely see them in NMO, at least in the brain. And then the extensive spinal cord lesions, basically about 3/4 of people with NMO will have a long lesion at some point. So one thing that was a bit of a surprise, now you may not believe me looking at this, but this is 327 relapses that we recorded out of our 75 patients with NMO, I keep using the wrong word, NMO, across Australia and New Zealand. And there appears to be a slight seasonal variation. Now, I have to say, when I first looked at this, that looked to me like a flat line with just some random variations, but we gave it to our statisticians, who plotted this sine wave to it and say that that is highly significantly different. So actually very similar to MS, NMO relapses seem to be more common in the spring and summer. It's only a very slight difference, but again, that's a little bit of a hint that there might be something to do with seasonal variation. Now, whether that's to do with sunlight, vitamin D, or some other factor, we don't know. The story in MS is that we think that relapses are more likely at that time of year because that's when your vitamin D levels are at their lowest, about 3 months after the sort of trough of winter, as it were, in terms of sunlight exposure. In terms of the types of relapse, as I've said before, most of them involve the optic nerve and the spinal cord. And if anything, the optic nerve relapses, or visual relapses, appear to be more common at a younger age. And then at greater ages, the spinal cord lesions appear to be more common. Interestingly, what Eugene Devick originally described of optic neuritis and spinal cord disease occurring at the same time, which is the little green bars down the bottom here, is actually very rare. And I suspect what Eugene Devick actually described originally as a different disease, which we'll come to in this slide. So the waters have been muddied yet further by the discovery of anti-MOG antibodies, and this is actually being very much driven by the group in Sydney who've discovered a test. We've known about this antibody for a long time, but it's been very complicated and murky trying to work out what it really means. But they've now got a test which defines very clearly 3 different patterns, one of which includes optic neuritis and spinal cord lesions, often very long spinal cord lesions, and actually even slightly longer lesions that go all the way down to the bottom of the spinal cord, which do occur in NMO but are not very common. And so some people are saying this is a subtype of NMO. Personally, I think it's anti-MOG disease, and that's what I prefer to call it because it's actually different. There are some different variations of it. But it's a specific antibody, and it seems to respond to very similar treatments. So, The incidence and prevalence in Australia and New Zealand of NMO appears to be very similar to other countries around the world where it's been looked at. In relative terms, it's about 1% of people with MS. And again, sometimes distinguishing between the two can be very difficult. It may be more common in people with Asian ancestry. So we've used the same mechanism to identify these cases, and we found it was about 3 times more common in the Asian population of Australia and New Zealand. It doesn't look to have a latitudinal gradient in terms of frequency by distance from the equator, but there may be a seasonal variation in the risk of relapses. And it's about 6 to 1 in terms of female to male frequency, and 30 to 40 is the commonest age, but it can occur at almost any age. And I think I'll stop there just to show you. This is, you'll probably recognise some of the neurologists that many of you in the room will see. So just to emphasise, this is not all me. This is all of these people who've contributed to this survey, and we all work very well together, and without all of their efforts, I wouldn't have been able to show you any of this data. And thank you for all of your support as well, for those who've participated. And if any of you want to be involved in our ongoing research, I'll give some details to Deb afterwards so that you can get in touch with us and be involved in it.